Well, thanks again for having me again for the second year. It really is awesome to come meet a lot of parents, meet a lot of the doctors, see them again. We're all colleagues, we collaborate, we talk to each other pretty often. So it's really a small family of specialists that really deal with this. So I'm going to take a little bit of a different approach. I'm going to kind of walk you through from the beginning, walk you through towards the end. And there are definitely philosophical differences as far as what we feel like in our hands is the ideal approach. But I will tell you though, all these approaches, when you deal with specialized surgeons, you can't go wrong, and no matter which technique you use. But it's really, really important that you do the research, and then you do ask all the questions, and not get caught up in all the hoopla. There's a lot of stuff out there right now that you have to be real careful with, and I've kind of made it really my mission is not to sell a practice, not to get patients to come in. We're busy, but just to make sure that you, I put myself in your position, your shoes, to make sure that you don't make any mistakes when you're looking for what technique to use, what surgeon to use, and things like that. So I'll give you kind of a real quick background kind of what I do and how I started. Same thing with Dr. Lewin. I never planned on doing any of this when I was growing up. You know, my main training, what I wanted to do was to become an ENT doctor, pediatric ENT doctor. I wanted to work with kids, didn't know what. Could have been orthopedics, could have been ophthalmology, doesn't matter. I just wanted to work with children. And when I got the exposure of pediatric ENT, I fell in love with it. And during my training, again, throughout Houston, Dallas, Buffalo, Pittsburgh, kind of everywhere, I had the chance when I was in Pittsburgh to see my first Microtia patient. This is in 1994. And at that time, our practice was specialized a lot or mostly in ear, whether it's ear infections, outer ear things, middle ear tumors, you name it. That's kind of what our focus was. When I saw my first Microtia patient, when I heard a little boy say he could hear the birds chirping for the first time in his life, I was hooked. And that's what I wanted to do, but I knew that there was just no way to maintain a practice because this is pretty rare. So that's where it kind of grew. When I came back to San Antonio, we actually had a lot of children with Microtia that were not being operated on because there was nobody there that was doing them. So my very first surgery 20 years ago was a Microtia patient. And since then, it's just the practice has snowballed to the point where I do this just exclusively only in children. So I love what I do. I'm just as passionate, and I mean, there's a lot of, obviously when we see the families here, these doctors love what they do, and that's what you really need to look for. So, what happens when, you have a child with Microtia? So many questions. Like Dr. Lewin said, what did I do wrong during my pregnancy? You just have all these unanswered questions, and many times, nobody gives you any answers. So I always really stress, when do you consult us? When do you talk to a doctor that deals with this kind of surgery? And I'll tell you that in a second. But basically, the initial shock is the issue. Why was this not found on the ultrasound? That kind of thing. And from that shock, once somebody speaks with you and you kind of get an idea more or less what this is, there's acceptance. Okay, my child has a Microtia, and it's going to be okay. Then after that, it's kind of an information gathering. Once you understand kind of what this is, then you kind of start doing your research and get on the internet and call doctors, and that's where the confusion starts. But that's where it's the most important to kind of hone in on the ones that do this a lot, and I'm talking about throughout the country, and not get misguided or not kind of veer off course. And then once all that's done, basically you raise your child normally. I always tell the parents we need to put all this into perspective. We all have to go through our normal emotions of having a child with a Microtia, once you kind of make it to that point, I always, when I talk to the parents, I say, let's put this into perspective. There's a pediatric intensive care unit in this hospital. Those parents they have a real problem. That's a lot more than what you have, and even worse, the pediatric oncology floor. These kids may not make it by tomorrow. That's a real problem. This is not a real problem. This is fixable. So, again, this is usually we want to make sure that the main medical issues are taken care of first. This is all secondary. Now, one of the things that happens is patients tend to be discharged from the hospital, and then sometimes we get called maybe a week afterward, or sometimes 3 or 4 or 6 years afterwards to let us know for the first time that there's a patient that has a microtia. So I kind of rearrange the order. Consult a microtia specialist if they're in the city first, and then before they get discharged from the hospital. So when is the perfect time to consult? With the day of birth. That would be the ideal time to talk to parents, talk to families, say, listen, it's okay. I know you're worried, you have to go through these normal stages, but it's okay. And you show them pictures and you talk about kids that have gone through your practice, and actually these kids are extremely happy and they do very, very well. So it's obviously very stressful. You go through all the same questions about, is my child deaf, those things. And once you kind of explain that to parents, they realize it's really not that bad. So reassurance, hope, and again, putting things into perspective, and again, it's not the end of the world. So I know a lot of you already know, because you've kind of seen this throughout media and stuff, but people can make it with a microtia and not get operated on until adulthood. So I know you guys know this person, the lead guitarist for Kiss, Paul Stanley. This guy, he played music. He talks about growing up with a microtia, growing up with being hard of hearing on that side, and look at him now, an extremely successful, very talented musician. This is the time I always tell parents, I use this as an example. Your kids have something that other kids don't have, is that they have that microtia, they have the ability to hear vibrations, to sense vibrations more than other children. So this is the time to get your kids in music, get them involved, because I have a lot of kids. My oldest microtia patient now is probably in maybe early 30s. And when he was in college, he was in the head saxophone, the front line, did extremely well. So I really stress to parents, they really do have advantages that other people don't have. So what is our role? Our role is, of course, understand the emotions involved. When you deal enough with these families, you run through the gamut of so many emotions: anger, fear, crying. That's all normal. But at the end of the day, once they realize it, they do really, really well. So it's a huge responsibility to take care of these children. I mean, we treat them as if they were our own kids. So we have to understand what they're going to go through from birth on through school age and even through adulthood. A lot of TLC. You tend to treat adults a little bit different. You tend to treat children. And many times you're treating the parents. You're not really treating the children. So once the parents understand, again, when these kids come in and they have a wonderful sense of confidence, it's all the parents. So it's really important for parents kind of to understand that things will be okay, and then kind of give that to your child. And again, most importantly, a lot of humility. This is something that, it's really an honor to take care of all these kids, and we have to remain very humble. Everybody will write you letters and writes you cards, and you're the best this and you're the best that, and thank you so much for it's fantastic. That's what keeps us going every day. But we have to be humble also that not every single child has a perfectly good result, or a perfect result, I should say. So it's important to give parents very realistic expectations of all of this. No matter what technique that is chosen, you do a zillion of these, and you're going to have some outliers that just didn't turn out exactly as you planned, but it's important for parents to know. And the plan is to have 99.9% of children look great, and that's what a practice is all about. So I'm going to repeat a couple things. Sometimes just a repetition is not too bad of a thing. Again, you've seen this picture of microtia. There's different grades of microtia, as Dr. Lewin explained. This is the classic microtia, the grade 3, and I know it's your grade 4, no ear canal at all. So the incidence, again, every 6,000 to 12,000 births, plus minus. There is a higher incidence in some populations, up to 1 to every 1,000, 1 to every 2,000 births. More common in males, greater right and left. In my practice, about 8%, 9% is bilateral, and I've got now a couple thousand children in my practice with microtia, and it averages about, it's kind of maintained steady about that percentage. So causes, we don't really know. I mean, the leading thought is maybe a decreased blood supply as the ear is developing. I have several children from South America. I have actually all triplets, and every single one has it. You have to wonder, there's got to be something genetic there. I have another family from South America as well that all the siblings have. There's 3 of them. They're like 2 years difference. They all have it also. So you have to wonder, well, there has to be something going on, but we really don't know. And then there's syndromes, of course, involved with this. And, Treacher Collins, you've got golden hearts, hemifacial microsomias. that Dr. Lewin spoke about. And again, we have a few kids that have, you know, a couple bilateral thumbs. And let's see, so I kind of simplify this pretty easily. There's two ways of looking at this. As far as the ear part of it, you just have two components, the outer ear reconstruction, and then you have the hearing part of it. They're kind of two separate. You can do things together, but they're two separate things. And as far as the hearing component, ideally you do nothing. Of course, you have an ear, you can open up the ear canal, then you have bone conduction hearing aids, bone anchored hearing aids, you have things, but if you kind of simplify it, it's rather simple algorithm that can lead you to the specialist you need to go to. So the anatomy, this is one of the hardest things to make. Let me see if I have my pointer here. Again, you have little triangles up there, you have little spaces down here. If you can achieve those, the ear looks really, really good. So it's rather complicated, but when things settle in beautifully, it looks fantastic. So the ear anatomy is extremely complex, and there's why that's very few doctors, neurotologists like Dr. Kessler, that can go through all this and fix these ears. So I break it down really easily: outer ear, middle ear, and inner ear. That's as simple as I see it. So I want to just show this slide just to kind of put things into perspective. So again, the outer ear is from the ear all the way to the eardrum. The middle ear space is right here. Kids get typical ear infections. And this is your inner ear, your balance mechanism and your hearing mechanism. But I just wanted to show you, this is kind of what things that the neurologists deal with. That bone right there is that size right there compared to a penny. These things are absolutely teeny. So you can imagine when these kids go and they're going to go have their hearing fixed, what these doctors have to do under a microscope to try to give these kids hearing. It's really amazing. It just boggles my mind every time I send these kids and they come back and they're hearing the work that had to go, stuff we don't really see, but we just know happened in the background. It's really amazing. But this book here is, I got asked a long time ago during one of my talks, have you ever read that book, Think and Grow Rich? And that's right, why would somebody ask me about growing rich and thinking and all? I just didn't get it. I said, no, Napoleon Hill, in one of his earliest editions, he's a real famous self-help author. You find this book in all Barnes & Noble and all these other places. His son was born with bilateral microtia. And everybody said, well, he's going to be deaf, he's going to be hearing impaired, he's not going to do well in school, learning disability. And he knew, by gosh, I know that my child's normal. And this was years and years and years ago. So one day he walked in to his son's room, and he found his teeth on the phonograph, as he says, and his teeth were actually on the record player. And he could hear sound like an orchestra beautifully. That's the whole theory of bone conduction. So it's just kind of a beautiful, it's great if you can find that book. It's a whole chapter about what he kind of went through with his son, you know, in the thinking that was, 50, 60 years ago. So basically we need to coordinate the hearing component with the outer ear component. One of the things about using the ear cartilage, if we want the children to go have their ear canal opened, that has to be done after the outer ear surgery, and I'll get into that in a few minutes. Any bone-anchored hearing aid, hearing device can be performed before, during, or after the cartilage surgery. So who goes first? Again, for the cartilage surgery, we have to go first. Anytime the children go first before we do, there can be scarring of the outer ear, and for the cartilage technique, it's very, very difficult to reconstruct an ear when there's a lot of scar there. And that's why when I see children like this, I personally don't think that the cartilage is the best option. There are other options there, so we go first. Now, I wanted to show this slide. See if I can, there we go, right here. This is just how important hearing is. And I just put this on about a month ago or so. I have a little bone transducer, a little processor that I put on this child's ear. And some say, yeah, they don't really need it, and they don't. I mean, they have a normal ear on the other side if it's on unilateral. And they can do perfectly fine, just like Paul Stanley did, for example. But when you can actually aid them just a teeny bit, this is just, again, this is non-solicited, obviously, he's a little child, but just to see his response when he starts hearing on that side with a little transducer. So, I'm going to put this right here.
What are you hearing?
And he stared at the camera.
Processor.
And again, this is a baby.
What do you think about that?
It's again, the beauty of sound. This really humbles us. It really does, because most of the time parents start crying and they realize, oh my gosh, because they can hear. And that's what we need. That's why it's so important to get to you early, because they can hear. I mean, it's muffled, but they have the ability to hear. They're not deaf. So just knowledge is just so important. Anyway, so I'm not gonna go through this too much, because this is Dr. Kessler, but there are several different types of ways we can help aid the children with hearing. So I'm gonna skip through this. There's different companies that do this. Let me go here. Okay, so let's start with the outer ear extension. So what happens? Okay, patient walks into the office, and like Dr. Lewin showed, how often do you perform microtia surgery in children? These are questions that are musts to ask any surgeon, no matter what you do. And I highly recommend opinions, because especially when kids are so young, you have years to look around, and you'll know who does them, who doesn't do as many. And once you start speaking with parents, and there's the social media, and it's exploded now, you can really have a pretty decent idea of who you should be kind of veered towards. So when we hear where our hospital performs, 50 surgeries a year, well, that really wasn't the question that was asked. Or our department performs a certain amount of surgeries. Again, not the question that was asked. The question is, how many surgeries has the actual doctor who's going to lay hands on my child performed? Again, we all go through training. We all do our very first surgery. But as obviously when the child's ours, you want to go to somebody who actually has done a lot of them, not just once in a while. So same thing, can I see before and after pictures? And I hear it all the time, well, no, patient confidentiality really can't show it to you. Not true. Parents are more than willing to share their pictures. You just need to get permission. How about, can I speak with families of children who have had microtia surgery with you? The same thing, And it's important to speak with families because, like I said, it's not a perfect science. And you will have some children that had a little bit tougher time than others. But in the end, it's really, really important that parents know exactly, what questions to ask. What is your complication rate? Will the ear look exactly like the normal side? Again, not an exact science. There are many more cartilage surgeries performed worldwide because cartilage surgery has been done for over 50-something odd years, if not more. So there's a lot of kids, and you're actually going to see a lot of, maybe not in the nicest pictures, kind of throughout the media there, because there's so many more surgeries that are done. But the key is those ones that are being put out there, how many surgeries have those physicians performed? Again, the MedPour technique, there are less surgeons that are doing it. Honestly, there's just really a few world authorities. I mean, you're in the best of hands here. Experience is critical, and it's just obvious with the pictures you just saw in the previous talk. So I really, really push that. Again, we're not here to sell a product. We're just here to tell you what we do in our hands. But it's really, really important that you really just ask all the questions. Never feel guilty about asking some hard questions, like, well, do you have problems with this? Do you have really bad results? Have you ever done this? Have you ever done? Those are really key questions. That's what we owe that to you. So anyway, so I just wanted, again, you may want to close your eyes if you're kind of, it's kind of some slides here. This is what comes through the office, and this kind of puts things into perspective. When we see 15, 20 kids in the office, every time we're in the office, we see this, and it's rather sad. And again, these are all completed years, by the way, and you kind of get to the point where you wonder, well, what happened? What happened to get them to this point? And most of the time, it's, well, doctor said to go see this doctor. That doctor said they would do it, and they did it, and that was it. There was never the questions asked, how many of these do you do? Let me get another opinion, that kind of thing. So I can keep, I won't, and these are all both cartilage as well as MedPour. It just happens, and you don't want to see these children coming through your office like this. So again, anytime that I'll skip that pretty quickly. Anyway, I'll story about this one real quick. But anytime that these children come through, I'm personally not a believer in performing cartilage surgery again on these kids if it was a cartilage reconstruction. I just don't feel that's in their best interest. They've already kind of been through enough. So there's two. I go straight for MedPour or anaplastology. Beautiful, beautiful results. So this is just a child who had both MedPour as well as cartilage in Mexico City, and parents said enough. So he had his little brother that came through that had the same thing. They said, we're out of here. So they came here to the States, and this is a little boy. I think I just separated his ear, so still a little puffy, but this is on his left side. This is his little brother. So what are the surgical options? Again, basic 4 surgeries: no surgery, rib surgery, MedPOR, and prosthetic. Those are basically your options. The cartilage, MedPOR, and prosthetic. Okay, so I'm going to skip through these and let me ask one thing about a prosthetic. All these children that come through my office, I felt really horrible because there was nothing much I could offer to them in my hands, because I don't do the other techniques. I just stick strictly with cartilage. So I flew up to Chicago, and I was trying to recruit somebody to come down here to help me maybe perform prosthetic ears on the children, and a plastologist. And one of the professors that was there, I thought was a professor, came up and he said, well, and I was in Mardi Gras, I got run over by a car, got dragged, and he looked perfectly normal. You would have never known. And as he was talking, he said, oh, by the way, I also got my ear replaced, and he popped his prosthetic off. It looked so beautiful. You know, we kind of get trained as last option, you know, that surgical is always the best in this. It really opens your eyes up to the beauty that a prosthetic can make. They can color it, they can put hairs on it. So I'm an absolute total believer. And anytime that anybody comes in with a lot of scar, again, my option is very simple. I wouldn't do the cartilage, not when there's so much scar. It's the 2 options, and I give parents, identify both of these options and go seek advice and opinions from these 2 options. So MedPOR and prosthetic. So timing of surgery, and this is the part that's really important. There's a lot of stuff out there about, I do this, it's almost like name that tune. Well, I can do this in 2 surgeries, I can do this in 1 surgery, I can do this in, you know, it doesn't really matter so much, whether it's rib or MedPOR or prosthetic, it doesn't matter, you know. What matters is the end. So there's even talks about doing the rib surgery in 1 surgery. It sounds great. We haven't been able to figure that out in 50 years. So it just sounds great, and we just don't want you to rush. And there is no rush. This child is going to live with this ear for the rest of their lives. So make sure that you don't get kind of caught up in that and all that hoopla. So like I said, it's just it's the final result that really, really counts. So okay, and I just put this slide up there, just 1 stage at a time. And I had a talk with Dr. Bert Brent, who is the guru of cartilage surgery, several months back, and kind of talked about what's out there in the world right now. And you know, we're just firm believers. And I'm talking specifically about the cartilage technique. You know, you stage these. You know, you do one, you make sure it looks good, and then you bring them back, and then you move on to the next one. It would be great if we could do everything in 1 surgery, but when you do everything in 1 surgery, it definitely can be done. And I'm talking about, again, cartilage technique, not MedPOR. And when you can do it all and you swing flaps over, you are really hoping that everything lays exactly where you want it. And you may have a child, 2 or 3, that look great, but ask about 100 kids or ask about 500 children. How did all those end up? And that's when you're really going to see the true answer. So personally, I'm not a believer in a 1-stage cartilage surgery. It's just not worth exposing a child. It just takes 1 child with a bad result that really breaks your heart and makes you see things in a different light. So I'm a firm believer in staging. Okay, so the advantages of cartilage. Again, we have different philosophies, and for doctors who perform cartilage surgery, they're not so much they don't believe so much in MedPOR, and some MedPOR doctors don't believe so much in cartilage. I don't believe that at all. I'm a huge believer in other techniques. I'm a huge believer in MedPOR. I'm a huge believer in prosthetic ears. They're just, you know, it all depends on your comfort zone and what you think is the right thing, but I don't think there is actually a wrong technique, so I'm just a firm believer. But again, in my hands, cartilage the ear's made out of cartilage, so you cannot match anything it's our own natural cartilage, our own living tissues. It won't break or fracture. It's alive and grows with the child. The skin color, because the cartilage is actually placed under the skin of the child, it's the same color as the side of the face, so there's no worry about a difference in color. No restrictions from any sports. And typically, you know, during the surgeries, it is 4 to 5 weeks of no heavy activities and like other surgeries. But when you're talking about in the big picture, they can do whatever they want. It's made out of cartilage, so it lasts a lifetime. And I'm going to go there. I've got this slide also about myths and the real facts. The cartilage surgery, it's dangerous. Well, it's extremely safe. Again, it's just imagine you do enough of these, and it just kind of becomes such a routine. It's very painful. Requires pain pumps. I had a patient last year from Canada that said, and they hospitalized him for 7 days No, no, they do extremely well. While I'm carving the cartilage, the anesthesiologist gives them a small little epidural shot. The kids are asleep; they don't feel anything. I've done this now for probably 15 years or so on every single child, and they wake up, and most of the time they have absolutely no pain in that area there because it's numb. And they go home the next morning on just regular Tylenol with codeine syrup. As far as multiple nights, of course, no, they go home the next morning. Takes 1 year to finish. In the old days, when it was historically 4 surgeries every 3 months, yeah, it would take a long time. Now they do so well. There's such little swelling most of the time that every couple months you can space them, and they can finish in 4 to 5 months. It's much more expensive. No, we have workings with insurance companies from all over the country that we have little mini contracts with them that we work very well with them. So parents' responsibility is usually not as much as in other states. Surgery takes a long time. Again, it usually takes about 2.5 to 3 hours average for the stages. So what are the disadvantages? Well, it's technically very, very difficult. It is one of those things that you see one and you can't really do one. You have to really see and at least have your hands involved in a lot of these before you really start getting, a little bit comfortable with this. It does require chest incision, but I just need to stress that because it requires a chest incision, that does not mean you're in the chest. You're not in the lung cavity. You're not in the heart. It's in that area there. You're basically going through little layers, skin, little fatty layer, and then the muscle layer, and then the rib is there, the cartilage is there. You take out the little pieces, and you close it up in layers. So it is in the chest area, but it's not chest surgery. I really want to point that to you. Another disadvantage, you start later than other techniques. Again, we start 6 to 7 years of age depending on size, and I don't mean weight, I mean height, because you have to have enough cartilage to be able to match the normal side. So, it does require 3 trips at a minimum. Most of the time, within 4 to 5 months, we're finished. And again, the ear canal surgery has to be delayed, or at least recommended to be delayed until after the cartilage surgery because you don't want scar there. So, unilateral, again, start at 6 years of age. Bilateral, start them also about 6 years of age. And these are basically the 3 stages. The first one is the big one. That's the cartilage surgery. That's when you make it a little incision. We try to keep it pretty small, about an inch and a half or more or less. Take out what you need, only what you need. You don't take, in the old days, they would take out blocks of cartilage. We don't do it. We just take exactly what we need to match the other side, and you insert into the side of the head, and that's it. Again, 2.5 to 3 hours, and they're waking up. Stage 2, that's the formation of the earlobe and deepening of the concha, which is kind of the ear canal area there. And then that's the second one. That usually takes about a couple hours. And the stage 3, again, a couple hours also. That's the separation from the ear from the side of the head. So it's performed in 2-month intervals and completed about 4 to 5 months. So it's really, really important. Again, all we do is deal with children. So as Dr. Lewin showed, it's so important to make these kids comfortable. I mean, I love the slides she showed with the cups and that's awesome. So the kids are scared. And usually parents are more scared. So we just need to reassure them. So you have to have the staff around you, the pediatric anesthesiologist around you that deals with this all the time to make these kids very, very comfortable, the nursing staff. I know I always joke with them, Elmo and Barney, when they come in, they get ear surgeries whether they want it or not too. So again, reassure the child. Again, this little girl she needed to have her doll there with her. So she's watching her go to sleep, and then of course waking up, they both have their little ear bandage. Okay, so one thing I do is I use a contact laser, which is basically, it's a real fine laser that separates the soft tissue off of the rib cartilage. So it's very, very minimal thermal burn, so they don't really hurt that much, and it's almost bloodless on the rib surgery. So I've been doing that for about 15 years as well, and it's been a night and day difference compared to the typical, we call Bovie electrocautery that we use. Stitches are small, about an inch and a half, and I put a little quarter up there just to kind of show you how small these things are. Again, these children get epidurals. These kids are asleep; they don't feel anything at all, and it's just a one-shot epidural. So harvesting of the cartilage, the sculpting. You take out 3 little pieces, and the first one is the first floating unit, which is this part right there. That's what you make the rim or the helix part of it. And then there's a little part in the middle there that's kind of a little combination of 2 small pieces of rib, and you suture those together, and that's kind of what it looks like. Then you close the skin up. So this is where the incision's made. You can kind of see where the ear is going to go, and again, the template is made from the normal side, so you match the normal side, And I put the slide up there for the reason to show that these children should all look pretty much the same when you finish the first surgery. These are just different sizes, different sides, different patients, obviously. The skin does coapt to the cartilage beautifully. I mean, and I wish I should have brought a video of when you put suction on the skin, you go from nothing to something. All of a sudden, the ear pops out right in front of you. It's really cool to see in 3D. This is a child just a week afterwards. And I do put a drain on these children to maintain that suction, because you want that skin to get to suction onto the cartilage. And once it scars onto the cartilage, then it won't. You shouldn't have any problems with bleeding under the skin and things like that. And once you're kind of done, the skin is relatively mobile as well on top of the cartilage. So I do remove the drains after 1 week. Again, it takes 2.5 to 3 hours. They go home the next morning. I remove the drains in 1 week. And the sutures usually a little bit after that, sometimes post-op day number 10. And then they can go home. Okay, so the second stage is the formation of the actual earlobe and deepening of the base. So this is just what it looks like. And this child was born just with this part right there. This part actually used to be up and down right here. So this is the reconstruction a couple of months later. This is what it looks like after with the earlobe in place, and once it's kind of healed a bit better. What I do is I form that little bump in front of the ear. It's called the tragus. That gives it the impression there's a little bump in front of the ear. And what I do is I go to the normal side and harvest a little bit of the skin and cartilage from the normal side, and bring that in and bring it to the microtic side and make that little bump there. So here's an example of a little boy that same thing. You know, he was born with this part right here. That was kind of up and down here, and this is his cartilage there, and you can see the little bump up there. So if you look at it from this angle, it looks like he has an ear canal. Of course, when you look at it from the side, you know he obviously does not have one. But this prepares it for surgeons such as Dr. Kessler to go in, if they're candidates, and open up that ear canal. They can have an awesome result. So length surgery about an hour and a half. They go home the same day. And this is the part that has always been tough for cartilage surgeons. Try to get that protrusion out there, because the ears tended to be relatively flat. And because when you separate the ear and you put a skin graft back there, the ear is going to go wherever the skull tells it to go. So even though they looked really, really good from the 45-degree angle, if you look from the front, they tended to be flat. And that always gnawed at me for years, until about 3 years ago, maybe about 250, 270 children ago, I started doing a different little technique. Again, I had a friend of mine ask me about the med pore, not for the outside part, but for the elevation part of it. And I operated on the first child and putting a real small little med pore wedge under the ear to see if I can give it a little bit more protrusion. And that was it. From that day on, I said this was the way to go. So it's kind of the best of both worlds. You know, you have, again, the way I see it, you have the natural cartilage on the outside. It's our own tissues, and you have the med pore wedge that's protected from the cartilage on the outside. So there's really no chance of breakage, because it's kind of flat. The med pore is flat onto the side of the head, so it can't break. So this has been it's changed the way I practice, and I think that problem that we had with the protrusion, we kind of figured that one out now. So again, you have your cartilage on the outside, and you have the hidden med pore on the inside. And here's this kind of med pore implant. Now we just use blocks and make a little wedge there on the top, and then I'm going to show you 2 or 3 slides here. So the ear is elevated off here, and then the med pore wedge is placed there. Then you bring in a little piece of a little flap that covers the med pore wedge. You have to have it covered. Sorry, and then. And that's kind of what it looks like once you put the skin there. And this is kind of the side view. Again, and by this time, you're talking a couple hours into it, it's starting to get pretty swollen. But that swelling always goes down. And, oh yeah, one thing I forgot also is, you know, the bone, the magnet implants now that are out there, you know, the bone conduction hearing aids, processors. This is the perfect time that we go in there and put those in as well. Through this same incision in the back here, okay? If they don't have that, then you do have to make a kind of a curvilinear incision this way. But to avoid that scar, you can do it under the exact same incision through the initial surgery. So you can put those in, whether it is the implant with a little abutment that sticks out, or it's the actual magnet. So a lot of new things have been pretty exciting in the hearing world right now. Okay, so the elevation you can kind of see now. These children are the wedge, you know, has worked well. Now, one thing I'm a firm believer, I'm a believer in not having the ears pop out too much. Because remember, our ears, they're made out of really thin cartilage. And if you were to harvest a really thin piece of cartilage, it will resorb, or it won't maintain its shape. So you have to make it a little bit thicker, but not thick enough to where it's too obvious. So I don't believe in having the ears come out too much. If it means having them come out a little bit more subtle, that is the perfect approach. So I could use a larger wedge, a 9mm wedge, and this ear can come out that much more. I don't want it to, though. I want it to be just enough to where it looks very natural from the side view and from the front view. And same thing here. He's still a little swollen on this side, but yeah, again, just from this angle, for me, that's more than enough using the cartilage. And the same thing with this child. You know, he just had his separation phase again. He hasn't cut his hair short. Most of these kids, at one point in time, they end up cutting their hair because some are still covering it up. But so he obviously has had, you know, you can see the elevation from that side. Same thing with this little girl. Started off with this, and you can see it's pretty even across the board. Again, you may measure 1 millimeter, 2 millimeters off. Again, in this world, that's not bad at all. So I don't worry so much about that little bit of distance. So they go home in a couple days. Now, again, complications extremely rare. The only time I've ever seen a pneumothorax, this is actually where the lung gets deflated during surgery, was 20-something odd years ago when I was in Pittsburgh. I've never seen that since. Infection, extremely rare, almost non-existent. Bleeding, extremely rare. Extrusion graft doesn't happen because it's our own cartilage. Displeasing appearance would be the most common, and because the surgery is done so often and by most surgeons in the world, really, there's a lot of children that come out with not the ideal result. But again, it's the same thing. Where are they getting their surgeries done? Is it in a university kind of setting where they do a few here, a few a year, or is it in a specialty place where this is kind of all they do? So the most common thing would be a displeasing appearance as far as a complication. And I can put all these slides up there again. That this is kind of what you really would want to avoid. Okay, so these are some of the children that in the past year or so that have had these surgeries done. And again, one thing I kind of stress is that because the cartilage is inserted under the skin will end up being this exact same color as the other side because it's just under the skin. Again, kind of the same thing. Yeah, and then again, these girls, it's interesting. It's a funny story because some of these girls, they're more interested in getting that earring put in than really finishing off their surgeries, and I'm sure Dr. Lewin can agree with that. They're more excited about that than anything. Okay, so here we go, just kind of before some afters. Now, I didn't bring any patients this year to the conference, but if you would like to speak with any of my patients, let us know, and we can give you as many phone numbers as you need. Let's see, so here's one. So, here's another one here. So kind of, again, when everything starts off very nebulous, a lot of questions, a lot of worries, what am I going to do with my child? Make sure that we all have to worry about, we don't want them to be teased, a zillion questions out there. After a while, you realize that, again, I always keep saying, it's not that bad, actually. These kids are extremely intelligent. They do very, very well, as long as they see the confidence from the parents. So the ideal is when we see them going outside and playing sports and doing whatever they do, and they've got this huge, smile on their face. You know that you have been successful in raising this child, and we've done well in at least speaking to parents and letting you know what to expect during the reconstruction. So I think that's it. Well, thank you very much.